All right, well, we're getting down to the meat of it now. So we're actually going to be talking about the sedation. Well, that being said, we're going to talk a little bit about the consent before the sedation as well. So before you start giving that sedative, we need to think a bit about the information that we're going to give that patient and a bit about that consent. And in order to find that information, we probably need to look at the Department of Health guidance on the topic. And they say that although completion of a consent form is in most cases not a legal requirement, the use of such forms is good practice when an intervention such as surgery is to be undertaken. Now, where there is any doubt about the person's capacity, it's important before the person is asked to sign the form to establish both that they have the capacity to consent to the intervention and that they've received enough information to enable valid consent to be given. Details of the assessment of capacity and the conclusion reached should be recorded in the case notes. So essentially, whilst you can get away without written consent in the emergency arena for the procedures that we're going to be performing, it's best to aim for it, along with a discussion of the intended benefits and potential side effects and complications. And if you haven't got a consent form to hand, and I can see that James will be scratching at the microphone when I'm saying this, and it's impractical to do so, then an entry into the notes to reflect that verbal consent was gained is highly recommended.
You're absolutely right. I can't disagree with any of that. But the only other thing I was thinking whilst you were talking about that, you talked about gaining consent prior to the procedure. It's also really important to think about all the other essential questions you want to ask before you sedate the patient. Because I'm pretty sure we've all been there when someone says, "Oh, so what's the patient's name and their date of birth?" And you think, "Oh man, I knew there was something." So just think about kind of what have you covered all the bases before you put the patient to sleep?
That did sort of come into my capacity assessment, James. But if you tend not to talk to the patient whilst you're doing your capacity assessment, then so be it. But no, I think what we're trying to get at here is the fact that you go for a procedure in hospital, an elective procedure. There is a significant part of that which is gaining the consent, and I think in the emergency environment when there is a time critical procedure that needs to be performed, it can be really easy for this part of the process to slide a bit, can't it? And we should really make every effort that we can to try and make sure that consent is really sought and understood.
All right, boys, what I think we need to do is actually get on with this sedation, though, isn't it? We've covered the consent and that is wonderful, but we're here to talk about that sedation process. So it's probably worth recapping where we're at right now, and then we'll go through some cases just to cement it all right at the end of the course. So the first things we want to just reconsider are, does this procedure actually need to be done, and does it need to be done now? Okay. The next things we're thinking about are, does it require or would it benefit from this sedation? So thinking about that layered approach, so the reassurance, the positioning, the analgesia, the regional blocks, all of the other things that come alongside this. And then, I think then we're on to making sure whether or not we've got the right people, the right equipment and the right environment to safely sedate them, aren't we?
Yeah, absolutely, Rob. And I think actually you've framed that nicely, because there's definitely 4 factors that I think about when I'm just about to build up to the sedation. And you've hit them there pretty much. So I always think about, have I prepared the equipment and the environment, the patient, the team, and the medications? And so let's have a quick recap, because we've sort of pretty much covered all those things so far, haven't we? So the equipment, we're preparing for the worst, aren't we? So don't forget things like, have you got your oxygen? Have you got your suction? Have you got your monitoring all hooked up and ready to go? Have you got your airway kit? And so on. We're always thinking about preparing for the worst. And for the environment, if we're pre-hospital or in hospital, we want to control that environment, make sure the patient's at a sensible height, if that's possible, well lit, warm, comfortable, you're not getting rained on, and so on.
Only you would mention that.
No, it's fair. It's a fair point, though. I think it's totally agree. You just got to think about maximising all of your opportunities, haven't you? Whether that be pre-hospital or in hospital, there's some easy wins to be had out there, and that's where you just need to focus before we get cracking. I think totally agree, James. Totally agree.
Thank you, Rob. Yeah, less of the abuse, Simon.
Sorry, mate. I know you don't like the wet hair look.
All right, so that is equipment and environment. Moving on to the patients, we've already talked about gaining consent. We've put the monitoring on. We've probably got 1, if not 2 points of access. I think it depends on how concerned you are about this patient, how much of a risk you think it's going to be. You've got your 360 access. Now, the next thing you want to do that we maybe haven't touched on is just describing the procedure to the patient. What are you expecting them to do? What are they going to experience? And just talk them through that process. I think this is all done in loads of different ways, isn't it? I think it's very difficult around gaining informed consent because you don't want to build them up and make them really anxious before you're giving them something like ketamine, for example, because then that's going to make things worse. So I think you have to be kind of pragmatic but realistic. That's certainly my approach when I'm explaining the procedure to the patient. Then we're thinking about the team, and we're going to do exactly the same thing to the team. We're going to describe what they're going to see. I don't know, in hospital, I guess this is maybe less relevant, but pre-hospital, don't forget you're going to be coming across crews who have maybe never seen a sedation before. And so if you put your patient down into the ketamine happy place, and then suddenly they're screaming out loud, and the crew's all wondering what on earth is going on, and that you've got all this totally wrong, that's not going to look too grand, is it? So preparing the crews, telling them what to expect, but also what their roles are. And we're making sure that we are allocating roles to everyone. So you're going to have a sedationist who's going to be in charge of the sedation. You're going to have the proceduralist who is going to do the procedure. And then you're going to have a number of assistants who can bring in defibrillators, scoops, stretchers, splints, whatever the procedure requires.
No, I totally agree, actually, James. And I think, I disagree with you thinking it's not as relevant in hospital because, there's such a fast sort of changeover of staff nowadays that you might not necessarily get people that you are completely au fait with sedation, and particularly, thinking of the effects that the sedation agents that we choose have and what the patient looks like. I think it's a really good idea, as when you're setting out your stall almost, to make sure that you do this every single time, even in hospital, making sure that, everyone knows what the patient's going to look like, what we're actually aiming for in terms of before we start the procedure, etc., etc. So, I know that it's definitely relevant for pre-hospital, but I would encourage in hospital to providers to take exactly that same approach, buddy.
Yeah, and I think this forms part of the checklist as well, certainly where I work. And checklists obviously become a big part of pre-hospital care and in-hospital care, specifically with things like an emergency anaesthetic, but they're also got a great place in sedation as well. And certainly talking through each of those roles, predicted difficulties and other aspects is a really good way to approach a situation.
Yeah, no, totally agree. And so then the last thing on my list, wasn't it, was preparing the medications. And so hopefully we've already thought through the patient factors, the scenario factors, what we want the sedation for, how long we want it for, the risk factors, the comorbidities and so on to determine our appropriate agent. We're also going to be thinking about any emergency drugs that you might want drawn up or ready to hand at least. So I think that's my checklist that I go through in my head. That's equipment and environment, the patient, the team, and the meds. But what about if you are the sedationist and maybe you haven't undertaken a sedation before, you haven't witnessed a sedation before? What are we actually looking at, or what are we looking for to direct our sedation?
Okay, well, that's going to be me then. I'm going to be the sedationist. So we're all happy. We're all ready. The patient's ready. And yes, I have confirmed his name and that he's got capacity. And then we're going to crack on with this sedation. So first up, we're going to ensure that if we need to give some opioids for analgesia, if that's not part of the sedative agent that we're using, that they're certainly given in enough time that that patient is going to be well analgesed when we give that sedative agent. We're then going to start titrating our medication, and we're hopefully going to have a nice calm room, nice and relaxed, and we're going to visibly watch that patient, keeping half an eye on the patient and keeping half an eye on the observations, anticipating how long it's going to take for the sedative agent to work, and really just watching to see that they're going through those different planes of consciousness and that they're getting to a depth at which you think it's then appropriate to start that procedure. You're going to be looking for things like a decrease in respiratory rate. You're going to be keeping a keen eye on saturations. You're going to be looking at the efficacy of the ventilation, and you're going to be keeping a keen eye on hemodynamics as well. And I think the one thing that's really key is that when you've then hit that appropriate level of sedation, you're then going to let your proceduralist know that it's then time for them to crack on with that procedure. It's really important to still have that control, because it's very easy for that proceduralist just to step in and get on with what they're going to do as soon as you start to put a bit of pressure on that syringe. As the procedure goes on, you're then going to titrate as you need to, thinking about the half-life of that medication, thinking about the top-up dose to keep, again, that plane of sedation appropriate until you get to the end of that procedure, and then you're going to start to wake the patient up. And that is, of course, with the caveat that nothing has gone wrong, no complications have occurred during that sedation.
Okay, that's a nice run through, Simon, there. Thank you very much. But I guess we also need to be planning for the worst, though, don't we? And James mentioned this earlier. So just thinking back to those that paper by Bellolio and thinking about the most common complications that you're likely to find. Well, the most common one was hypoxia in about 4% of cases, then vomiting, aspiration, laryngospasm, and ultimately intubation in some cases, but that was really low at 0.1%. So these are the most common things that you need to be ready for. Now, essentially what we need to do is we need to ensure that we are supplying that patient with supplemental oxygen to support them through the periods of that relative hypoventilation while we're making sure they're on that right plane. Now, obviously, if the patient obstructs their airway and becomes hypoxic, then simple airway positioning and supplementary respirations via a bag valve mask or whatever it is that you have to hand may be required. But this definitely should not be commonplace. So this should be a rare event. So there are occasions when the patient might also develop excessive secretion. So obviously direct suctioning in combination with just simple postural drainage, so head turned to the side or patient themselves turned into a lateral position, can help with this. But I think the thing that we're most concerned about, and frankly the most scary complication that we're going to see, is laryngospasm, isn't it, boys? And this is where the vocal cords oppose and there is an obstruction to gas flow in the trachea. And that's when things get pretty hairy, don't they?
Mm-hmm.
They do indeed. And laryngospasm, so as you've said, is that clamping down of the cords and that obstruction. So it can come on without much of a warning, which is, just in case you really want to scare yourself, it can come upon you without any advance notice whatsoever. And it may be preceded by a high-pitched inspiratory stridor, much like the high-pitched noise that you'll make when you realise that they've got laryngospasm in front of you as well. And you get what is described as a bit of a crowing noise as well. But what you're going to see with that obstruction, so it's not just the noise that you're going to get from the upper airway, but you will see physically that respiration has either been completely halted and that your end tidal will have dropped off as a reflection of that, or actually that the movement of the chest becomes a bit paradoxical before it then completely obstructs. So this is when that really keen eye on that patient and keeping a really sound view of their observations is really, really important.
Yeah, it certainly is, Simon. And obviously that is covered through your preparation of the patient and all of the monitoring that you're going to be setting up prior to this sedation starting. But what are we going to do about this laryngospasm? Well, there's a few different options that we can attack this with, but I think one of the most consistently discussed options is that of PEEP. Now, that might be pretty challenging, actually, if you're going to be doing this pre-hospital, and actually you might not have any options other than maybe providing some positive pressure through a BVM and a mask. But if you're in hospital or if you've got access to it, then obviously a water circuit is also a pretty handy bit of kit to provide some PEEP. But if you find that doesn't break the laryngospasm, then sometimes deepening the sedation, so giving more of the agent that you've already administered, can help, because sometimes that laryngospasm is attributed to a patient who's slightly stuck in this grey zone between a sedation and full consciousness. And the thinking there is that if you deepen the sedation further, then actually that laryngospasm may break. But in the worst case scenario, and in extremis, we may be needing to escalate to an RSI. And actually that's why some of the guidelines that you'll have for your organisations will advise that actually when you're doing a sedation, you need a clinician either on hand or immediately available who is able to provide that anaesthetic.
Yeah, and I think having that structure of that stepwise approach is really, really important. And actually deepening a patient when you're experiencing a problem can almost seem like quite a counterintuitive thing to do, can't it? Because you're in this situation because you've started a sedation, and then what are you going to do about it? Well, you're going to sedate them a little bit more. But but that's because the reflexes are still intact, isn't it? And what you're basically trying to do is to overcome that either through mechanical forces with your PEEP or through cheating with chemical forces as well. So yeah, it might it might feel like the wrong thing to do, but it certainly is the right way to go.
Yeah, absolutely. Totally is. Now, the last complication that I think we need to cover in this section is hypotension, which, might be seen a little bit more frequently than you're going to see laryngospasm, you'll be pleased to know. But there are some things you need to have considered. And as we said too many times now, the patient, their comorbidities and their acute injury or physiological state need to be taken on board here. Now, it's clearly, and I think a really sensible and prudent idea, to have some IV fluids hanging or just dripping slowly next to that patient when you're giving this sedation, so that you can bolus as required, whilst it also works as a flush for the line, as in for the medications and things. Now, the other thing that I think is probably quite prudent, and you'll certainly see in UK practice, is having a medication such as metaraminol to give them some alpha squeeze on hand to combat that pharmacologically induced hypotension is a really good idea if you've got it with you.
Yeah, and I think this is one of those complications that you're really going to try to make sure it doesn't occur, because this is almost invariably due to the amount of sedative agent or opioid that patient has received, isn't it? So once you've seen it, you certainly will pay more attention to it the next time. But having talked about it here, then hopefully the focus will be on there in the first place and it won't be a complication that you're going to have to manage. So in summary, we've had a think about the key part of the course. So we thought about the sedation and the procedure. Before you get to giving sedation, make sure that you consent your patient as well as you possibly can. We've described that might not always be on a consent form, but at least alluding to the process that you've been through in the notes is really important. Having an approach in your mind for how to get everything ready for the sedation is really important by getting your 4 sets of things ready. So your equipment and environment, your patient, the team around you, and your medication. Then when you go on to perform that sedation, keeping a really close eye on that patient and titrating your sedation to what you see in front of you and paying really close attention to the response, both physically in front of you and to those observations on the screen. And then having a good framework in your mind for how to deal with commonly encountered complications is going to really get you out of some holes, which can be hugely stressful if they occur without you having thought about them beforehand.